Welcome you all. My name is Dr. PJ Madam Rafi. Today we are going to discuss about asthma and its management. Okay. So first, what is asthma? Asthma is a Greek word. It means difficulty in breathing. It is a chronic. Asthma is a chronic inflammatory disease in which patient suffers from reversible episodes. Okay, these are reversible episodes of airway obstruction due to bronchial hyperresponsiveness. Patient in this asthma patient will have bronchial hyperresponsiveness. Due to this bronchial hyperresponsiveness, airway will get occluded. Okay, and this is reversible episode. Once you get treated, patient will get settled down. Again, you will have, and if you have trigger point, then the patient will have bronchial obstruction. Okay, that's why it is a reversible episode, and the patient will have bronchial hyperresponsiveness. Due to this bronchial hyperresponsiveness, patient will have airway obstruction. Okay, due to this airway obstruction, patient will not able to breathe. In this asthma, we have types that are extrinsic asthma, intrinsic asthma, cardiac asthma. Extrinsic means patient will develop asthma due to pollen grains, dust, and mites. Okay. Intrinsic means non-allergic. It means patient will have internal problem because of other diseases or stress induced. These are intrinsic related. Extrinsic means it's some outside, whether with pollen, dust, mites. Cardiac means due to uncompensated heart failure, patient will have triggering point for asthma. Okay. Among these three types, they have some other special types also. Those are exercise induced asthma, aspirin induced asthma, brittle induced asthma. Exercise induced asthma means when patient will have doing some exercises, this asthma will get triggered out. Okay. Next, aspirin induced asthma means when patient is on aspirin, aspirin is inhibited. What the aspirin will inhibit amino acids. Okay, so when the cell membrane will have arachidonic acid, this arachidonic acid will get inhibited. Once it will get inhibited, this arachidonic acid will converted into 5-hydroxy ecosteronic acid. Okay, when this 5-hydroxy ecosteronic acid will get formed, it will be converted into lipoxins. These lipoxin will be trigger point for bronchial hyperresponsiveness and bronchial obstruction. Due to that one, patient will develop asthma. Okay, that is aspirin induced asthma. Due to aspirin, 5-HETE will be formed. This will be converted into lipoxins. This lipoxin will induce bronchial obstruction. That will induce asthma. Okay. Next, brittle induced asthma. Brittle induced asthma is a drug resistance asthma. That drug will be beta 2 agonist. Okay, this is an MCQ recently asked. Okay, next. Next, we'll see pathophysiology of asthma. Okay, in pathophysiology, first is when antigen is sensitized individual. When antigen is entered into body, body will develop IgE antibodies. Okay, these IgE antibodies, they have memory which remains in the blood by attaching to the mast cells or basophils. Okay, these cells will have memory for that antigen triggering point. Okay, and the same patient will re-expose to the same antigen. Those mast cells will get underwent degranulation. These degranulation will lead to release some inflammatory mediators. Those inflammatory mediators like histamine, serotonin, prostaglandin, leukotrienes, cytokines. These are inflammatory mediators. They will cause bronchoconstriction and inflammatory responses. These response will be two phases. One is early phase, in second is late phase. Early phase patient will develop bronchoconstriction. Late phase patient will have inflammation, pulmonary edema, mucus secretion, and bronchial hyperresponsiveness. Okay. So based on this triggering inflammatory mediators, patient will have bronchoconstriction in early phase. Late phase patient will have inflammation, pulmonary edema, mucus secretions, all these. Okay. Okay, next we will see the treatment part. In the treatment part, first drugs will be bronchodilators. Bronchodilators will be the main drugs. These are rescue drugs. Why rescue drugs means in asthma, what is the main pathology? Bronchial constriction. So when you are using bronchodilators, these will allow the air entry and patient will get relief. Okay, these are the main rescue drugs. What are the functions of these drugs? Means they relax smooth muscles, bronchial smooth muscles, thereby bronchodilation will be happen. But these bronchodilators doesn't control disease process. Okay, they doesn't have any impact on disease process. They will mainly cause bronchodilation. That's all. In bronchodilators, we will have selective beta 2 agonist. In those selective beta 2 agonists, we have two types: short acting, long acting. Short acting will have salbutamol, terbutaline. Long acting will have salmeterol, formoterol. These actions will be mainly they will relax smooth muscle, thereby bronchodilation will happen and inhibit the release of inflammatory mediators. So thereby hyperresponsiveness, the inflammatory mediator trigger point also get controlled, and they will increase mucociliary activity, thereby accumulation of mucus in the bronchioles will get released out of the body. So patient will get relief with that one also. So these are the major three actions, thereby patient will get relief. And because of using of these drugs, they have some other effects also. Those are adverse effects. Those will be muscle tremors. Why? Because of muscle tremors. Muscle will have beta 2 agonist, so obviously those patients will have muscle tremors and tachycardia. This is reflex tachycardia. Okay. So these are the two adverse effects with beta 2 agonist. The main action will be these are bronchodilators, so we call as a rescue drugs. Next group of drugs we have is non-selective sympathomimetics. These are non-selective. In that group we will have epinephrine, ephedrine, isoprenaline. These drugs will not use commonly in emergency situation. If you don't have other drugs like salbutamol, steroids, this one beta 2 agonist and steroids, we will use these drugs. Mainly epinephrine. Epinephrine will use as a nebulization or subcutaneous injection in emergency situations. Next, anticholinergic drugs. These drugs are we are adding as a combination therapy. In these drugs, we will have short-acting muscarinic antagonist, long-acting muscarinic antagonist. In short-acting, we will have ipratropium, oxytropium. Long-acting, we will have iotropium, glipironium. Okay, these drugs will reduce cyclic GMP. Cyclic GMP when get reduced, obviously they cause bronchodilation. Okay, so cyclic AMP increase bronchodilation, and inhibition, decreasing of cyclic GMP also cause bronchodilation. So these drugs main side effect is urinary retention because of anticholinergic property and decrease mucus secretion. Okay, obviously mucus secretion will get decreased. Next group of this drug will use as a add-on therapy. Combinationally we will use. Okay. Next group will be methylxanthines. These are also main drugs in treating of asthma. In this group we will have theophylline, aminophylline, doxophylline. These drugs will act through inhibiting phosphodiesterase enzyme. This is the main enzyme 3 and 4. By inhibiting this enzyme, it will elevate cyclic AMP level. When elevating cyclic AMP level, it will cause bronchodilation. Okay. So obviously patient will get relief. So they will have other property, that is blocking of adenosine receptor on smooth muscles and mast cells also. Thereby mast cells degranulation will be inhibited and adenosine receptor inhibition also causes bronchodilation. Next, these drug will have other actions like other than bronchodilation, they have anti-inflammatory and immunomodulatory effect also. These drugs we have to use very carefully because they have a very narrow therapeutic index. So if you are using abruptly or more doses, they will have causes toxicity. So the narrow therapeutic index will be 10 to 20 micrograms per milliliter. So we use this drugs used to be has very careful monitoring. Okay. Next will be coming to the next group. In next group we will have corticosteroids. Okay. Corticosteroid group drugs will called as controllers or preventers. Okay. Beta 2 agonists are rescue drugs. These are they will prevent the disease progression. Beta 2 agonist drugs, they don't have any involvement in disease process. These drugs will involve in inhibiting of disease process also. Okay. They enhance beta 2 receptor response by upregulation. That means they will increase the receptor level of beta 2 agonist. Thereby, if you are adding beta 2 agonist drugs, they will cause more bronchodilation. Next is they inhibit inflammatory mediators like prostaglandins, leukotrienes, interleukins. Thereby, inflammatory mediators will get obstructed. In this group, we will have two types: inhalation drugs, oral drugs. Inhalation drugs will have beclomethasone, fluticasone, budinasone. This will be used as a nebulizing, okay, nebulizing agent. Inhalation. Then oral steroids will you prescribe as a OP base. Those drugs will be prednisolone, prednisolone, methylprednisolone. Okay, these drugs will be main controller and preventing of asthma. Okay. Next group come to next group. In next group we will have mast cell stabilizers. Mast cell stabilizer. In this they mainly stabilize the influx of calcium ions, because when calcium ion will get inhibited, there will be no degranulation of mast cells. So obviously no inflammatory mediators will get released. So there will be no airway hyperresponsiveness, no triggering of asthma. So in this group we will have drugs like sodium bromoglycate, udocronyl sodium. Next group will have leukotriene modulators. Those are jaffrelukase, montelukase. They will be prescribed mostly in the night time. Okay. Next will be antibodies. Those will be monoclonal antibodies. In this group we'll have omalizumab. Next, other group drugs will be nitrous oxide. Nitrous oxide is also bronchodilator. It is a non-adrenergic, non-cholinergic neurotransmitter also. It will also cause bronchodilators. Okay, that's why it will decrease also asthma. But mostly we will not use. We will use mainly beta 2 corticosteroids and anticholinergic drugs. Among these three, we can use leukotriene modulators to control prophylaxis. Okay, conditions. Next. Next, in asthma, we'll have one special condition that is called status asthmaticus. Okay, status asthmaticus is a severe acute asthma cause. It is a severe acute asthma causing life-threatening by developing exhaustion of patient, cyanosis, bradycardia, hypotension, dehydration, finally metabolic acidosis leads to death of the patient. Okay, so main symptoms will be cyanosis, hypotension, brady, dehydration, metabolic acidosis. All these will induce death of the patient. So it is a very severe condition. We have to treat immediately. How to treat? We have to connect high O2 concentration with high flow rate because of patient who is having cyanosis. Next is high dose of inhale short acting beta 2 agonist. We will not using long acting because we need emergency response. So immediate response we will use short acting beta 2 agonist like salbutamol, terbutaline. Next, high dose IV corticosteroids because we need to increase beta 2 response activity and decrease inflammatory mediators production. So thereby we will use IV corticosteroids, methylprednisolone, prednisolone, dexamethasone, like that only. Next, ipratropium bromide, it will be additive therapy because of this have anticholinergic, decrease mucus clearance, increase mucus clearance. So obviously it will be beneficial. Next, in last option we will go with epinephrine. Epinephrine will give subcutaneous or nebulization. Okay, because if you don't have drug, we will go for epinephrine because it's a life threatening. We'll use epinephrine also. Next, we will correct dehydration and metabolic acidosis by soda bicarb or by giving IV fluids. We'll correct these two also. So this is how we will treat status asthmaticus. This is an emergency condition. We have to treat immediately. Otherwise, patient will be collapse. That's it. Thank you.